Hi, this is Dr. Nancy Tierney. This video will be a summary of the 2013 guidelines for lipid management and will include the high points. There will also be several patient scenarios that show application in patient care. The guidelines identify high-intensity statin therapy as well as moderate-intensity statin therapy, and the four groups of individuals who have been shown to derive the most benefit from these types of statin therapies. To review, high-intensity statin therapy is comprised of atorvastatin 40 to 80 milligrams per day or rosuvastatin 20 to 40 milligrams per day. Moderate intensity statin therapy is defined as dosages of these specific medications at these specific dosages. I'll give you a few seconds to review. The four groups that derive the most benefit from statin therapy will be the next few slides. The first group has been identified as individuals with established clinical atherosclerotic cardiovascular disease. This has been defined as documented or proven coronary artery disease, prior stroke, or peripheral arterial disease that has been shown to be atherosclerotic in origin. The treatment for this group of individuals is high intensity or moderate intensity statin therapy. The choice of which therapy to use will depend on their age and the safety of using statins in this group. The second group has been identified as individuals with LDL cholesterol levels of greater than or equal to 190 milligrams per deciliter who have familial hypercholesterolemia. High-intensity statin therapy is the treatment of choice for individuals in this group. Again, if they are not a candidate, then moderate intensity therapy can be used. The third group has been identified as individuals ages 40 to 75 who have type 1 or type 2 diabetes and an LDL cholesterol level of 70 to 189 milligrams per deciliter. Treatment is moderate intensity statin therapy, except in those individuals who have an estimated 10-year risk for ASCVD of greater than or equal to 7.5%, which we'll touch on in a bit. The next group of individuals has been identified as those with ages 40 to 75 years, have no atherosclerotic cardiovascular disease or diabetes, and have an estimated 10-year ASCVD risk of greater than or equal to 7.5%. The treatment is either moderate or high intensity statin therapy. Let's do a patient scenario. You have a 55-year-old man in your office who had an anterior wall myocardial infarction 8 weeks ago. He had a cardiac catheterization and was found to have significant atherosclerotic plaque in his LAD and his RCA. He had an intracoronary stent placed in his LAD. You want to start him on statin therapy for his coronary artery disease. According to the current guidelines for treatment for lipid management, this patient meets criteria for A, starting moderate intensity statin therapy, B, obtaining a lipid panel before initiating statin therapy, or C, starting high intensity statin therapy. The answer is C, starting high intensity statin therapy. This man belongs to the group of individuals who have established or documented ASCVD, which he has with his cardiac catheterization. He is also less than 75 years of age, and there were no identified safety concerns with statin use. Which of the following would you prescribe for this patient requiring high-intensity statin therapy? Rosuvastatin 20 milligrams daily, atorvastatin 10 milligrams daily, simvastatin 10 milligrams daily, or pravastatin 20 milligrams daily? The correct answer is rosuvastatin 20 milligrams daily. As you recall from one of the first slides, torvastatin 40 to 80 milligrams daily or rosuvastatin 20 to 40 milligrams daily has been identified as high-intensity statin therapy. Answer B is actually moderate-intensity statin therapy. Answers C and D are frequently prescribed in clinical practice but are not part of the guideline recommended treatments for the patient in this scenario. Next case. 26-year-old woman has an LDL of 260 milligrams per deciliter, an HDL of 51 milligrams per deciliter, and triglycerides of 102 milligrams per deciliter. She reports having elevated LDL-C levels of over 200 milligrams per deciliter since her teens. She's been on various diets but been unsuccessful. She's never taken a drug to lower her cholesterol. She's worried because her father died suddenly at age 38, and her father's brother had an MI at age 32. Both were smokers. She has an occasional cigarette and says that is considered social smoking. On exam, her blood pressure is 110 over 60 millimeters, and her BMI is 24. She has bilateral inferior pole corneal arcus, no xanthelasmas. Her cardiovascular exam is normal. Based on your assessment findings, your patient education will include the following discussion. She has familial hypercholesterolemia and should start a high-intensity statin. Her occasional social smoking is okay for now. Or she should have an estimation of her 10-year risk of ASCVD before deciding if she needs statin therapy. Correct answer is A. She does indeed have familial hypercholesterolemia, which places her in the statin benefit group. A clue to this is adults with LDL cholesterols greater than 190 milligrams are more likely to have a genetic cholesterol disorder, which places them at high risk. Therefore, statin therapy should be started by age 21 or before. Individuals with familial hypercholesterolemia should never smoke. Research has shown that cigarette smoking greatly increases the rates of cardiac events in younger women as well as younger men. It also can be partially explained for myocardial infarction in her father and her paternal uncle. In adults with primary LDL-C greater than 190 are already identified in a statin benefit group, and therefore it's not necessary to calculate a 10-year risk in these individuals. You want to provide counseling about dietary choices for this patient. Information to give her initially and in follow-up office visits include diet low in saturated fat and trans fats and soluble fiber, reduced calorie intake, vitamin E supplementation, and the nutritional supplements containing cytostanol esters. This is a little bit more thinking involved. The answer is D. She needs to be counseled on nutritional supplements containing cytostanol esters. These are plant sterols which have been shown to reduce serum cholesterol by inhibiting cholesterol absorption. A diet low in saturated and trans fat and high in soluble fiber is recommended, not low in soluble fiber. Her BMI is normal, so she doesn't need calorie reduction. And vitamin E supplements are not recommended. There's no evidence supporting its use, and some studies have shown that there is a blunting of the benefit of anti-dyslipidemic medications with vitamin E. References are shown here. I will also be sure that these are available in the classroom on Blackboard. They include the full report of the 2013 American College of Cardiology's American Heart Association guidelines, as well as a summary of information. I have also included a CV risk calculator so that you can estimate ASCVD risk, and there are also apps available. Thank you.